Okay, so Stevens-Johnson syndrome and toxic epidermal necrolysis, just see it as a spectrum, right? So the milder version, not to say that it's not a severe skin disorder, but the milder version is Stevens-Johnson. The more severe version is toxic epidermal necrolysis. And it's really just based on the extent of skin that's involved, right? They're both very serious conditions, okay? And basically the epidermis is sloughing off of the skin. It's just falling off, right? So very serious. So both can lead to fatal, both can lead to fatalities, especially toxic epidermal necrolysis, since it's more severe. And it can occur on the skin or the mucous membranes, so in the mouth, the eyes. So it can be really severe inside the body and outside the body. Okay. So with this skin that's sloughing off and the inside of their mouth the tissues falling off, they can develop a lot of complications from this. So what kind of complications can occur from this? Well, dehydration from all the skin loss, sepsis because of the bacterial invasion from this compromised skin. You can get pneumonia because the mucosa can be infected down the throat. And finally, all of your organs can fail, okay, from dehydration and sepsis. So typically people present with fevers, blisters, their skin's peeling off, their eyes are red, they've got ulcers in their mouth. Okay, now what usually causes this? Typically it's caused by medications or sometimes from just a simple infection, such as a virus. Okay, so what are some common drugs that are notorious for this? Well, some of the anti-seizure medications can do this. Carbamazepine. So just think of the anti-seizure group as causing Stevens-Johnson syndrome. Allopurinol for gout can cause this. And the most notorious antibiotic is sulfa. So sulfonamide antibiotics. Okay? So either medications or a virus can cause this. Okay? If it's greater than 30% of the skin, then it's called toxic epidermal necrolysis. If it's less than 30%, then it's Stevens-Johnson syndrome. Okay. So if we look at the images there, you can see the sloughing of the skin. If we look at assessments, so we look at the skin, we look in the oral cavity, we look at the eyes. In terms of vital signs, they're febrile. They can have problems breathing because of all the sloughing of the mucosa in the back of the throat. Hypotension, tachycardia because they're losing fluids. They can have decreased urine output because they're dehydrated. Okay. We have to watch for signs and symptoms of infection, such as cellulitis or a pneumonia developing. Okay, so pretty severe rash and illness. Okay, and a serious complication that can lead to death is sepsis. So TEN and Stevens-Johnson syndrome, which, as I said, are one and the same, really. What's the treatment and the interventions? Well, one of the first ones is really kind of viewing this as a burn. Your skin is sloughing off, right? So maintaining skin and mucous membrane integrity, and protecting the remaining skin. So often the dead skin needs to be debrided off the body because it's just a source of infection. So dead skin needs to be debrided off, waiting for new skin to begin. Okay. So maintaining fluid balance with IV fluids would be important because you can imagine with all this missing skin, there's going to be a lot of loss of fluids and electrolytes. Okay, preventing hypothermia, again, because your skin's been lost, you've had significant loss of skin, you can lose a lot of your body temperature. Pain relief with analgesics, because of all the skin sloughing, it's extremely painful. Prevention of infection is really important in these patients. So all of these are potential complications, right? So skin infection, sepsis, pneumonia, hypothermia, hypotension, electrolyte disturbances, all of those can occur, okay? And if you get sepsis, well, now other organs are in trouble. Your kidneys will be in trouble from hypotension. Your lungs can get into trouble. So it's a bit of a cascade. So really a lot of this is monitoring, maintaining fluids, preventing infection, avoiding hypothermia. Okay, so I've looked over this slide. I'm going to leave this slide. I don't have a lot to add to it. So again, in the interest of time, I'm going to move on. And we're almost there. Okay, so let's do the questions at the end of chapter 74, and I think we're done for this module. Okay, so number 1, a nurse is providing information about a new prescription for corticosteroid cream to a client who has mild cirrhosis. Which of the following instructions should the nurse include? Apply an occlusive dressing after application. You could. I mentioned that you can put corticosteroids on and then put some kind of occlusive dressing so that the corticosteroids really penetrates the psoriasis. So that's not unreasonable. Typically we do it with more severe psoriasis, but it can be done with any psoriasis. It'll just it'll penetrate better. Apply 3 to 4 times per day. Corticosteroid creams are usually applied twice a day, once or twice a day, not 4 times a day, because of the thinning of the skin that can occur. Okay. Wear gloves after application to lesions on the hands. Wear gloves after application to lesions on the hands. Well, you can. That's just like occlusion, though, right? So by putting gloves on, it's just going to do the same as answer A. It's just going to occlude it and allow for the corticosteroids to penetrate the area better. Okay. D, avoid applying to skin folds. That's probably a good idea. Corticosteroids, remember, they suppress the immune system locally, so they have local immune system suppression. That's why when you take a fluticasone inhaler, so a cortisone inhaler for asthma, you rinse your mouth out after. Well, it's the same on the skin, right? So in a fold, if you're applying cortisone cream, it's going to stay there because it's in a fold, and it sets up the person to get tinea, so a fungal infection in the fold. So it just increases the chance of developing a skin infection. Okay, I don't really like this question, by the way. So the answer is A, C, and D. Oh, sorry, there's one more. Use medication continuously over the period of several months. No, that wouldn't be a good idea because of the fact of its adverse effects of thinning the skin. Okay. Okay, number 2. Nurse is teaching a client who has a history of psoriasis about photochemotherapy and ultraviolet light. Which of the following instructions should the nurse include in the teaching? Apply vitamin A cream before each treatment. No. With PUVA treatment, usually you have an injection of what's called Sorolin, a medication, which then you receive the UV light, and it has a beneficial effect for psoriasis. So you wouldn't apply vitamin A cream before each treatment. Administer a psoralen medication before each treatment. So that's correct. Okay. It enhances the photosensitivity. Use this medication every evening. No, you'd have to go somewhere and get this, and it's usually 2 to 3 times a week. Remove the scales gently following each treatment. No, you wouldn't remove the scales. You wouldn't pick at psoriasis. You're just going to set up an infection. Okay? So the answer is B there. 3, a nurse is educating the client on the use of calcipotrione. That's a vitamin D analog for psoriasis. Which of the following laboratory values should the nurse monitor? So it's going to be calcium because it's vitamin D related, right? So it can lead to hypercalcemia. 4, a nurse is providing teaching to the guardian of a child who has contact dermatitis. Which of the following information should the nurse include? Use fabric softener dryer sheets when drying the child's clothing. No, you're just adding another chemical to the mix with a dryer sheet, so not a good idea. He may have contact dermatitis to the dryer sheet. Apply a warm, dry compress to the rash area. You wouldn't usually apply a warm, dry compress. If you wanted to settle down the itching, you could put a cool compress on it. Place the child in a bath with colloidal oatmeal. Sure, that really helps with itching. Right? So they don't mention it, that the patient's itchy here, but it really helps with itching of contact dermatitis. Leave the child's hands uncovered during the night. Okay. If the child is really itching and scratching, they're going to potentially set up a secondary skin infection. So sometimes you just can't do that in a young child that doesn't know not to scratch and itch. Okay. So the answer is C here. 5, a nurse caring for a client who has contact dermatitis and has a new prescription for diphenhydramine. Okay, so Benadryl, an antihistamine. For which of the following adverse effects? Definitely it's going to be anorexia. Okay, I'm not a big fan of that question. So diphenhydramine is usually sedating. Okay, it's an antihistamine and it's sedating. It has anticholinergic effects, so it's going to give you a dry mouth, not increased salivation. And it usually makes you sleepy, so D would be wrong. Insomnia is lack of sleep, so that's not right. Elevated blood glucose levels? No. The main adverse effect of diphenhydramine is fatigue and sleepiness, and it's not here. So I would be left with B just by a process of elimination more than anything else. Okay. I hope that helps. I'm sorry about the ETI questions. Not all of them are clear, but we'll just keep on doing them. Okay. See you next time.